I am so excited and pleased to have these two CEOs, leaders in the healthcare space with us today. Maria Ghazal, President and CEO of the Health Leadership Council, on my far right, and Susan Dentzer, President and CEO of America's Physician Groups. And we're going to focus on various challenges in leading healthcare organizations right now and representing the members that they have. And we'll sort of touch on some intersection in Medicare Advantage. And where I thought we would start is being able to hear from Susan and Maria on their organizations, who they represent, and speaking to some of their priorities.
Great. Well, thank you, Mary Beth. It's great to see you, and good morning to everybody. First of all, I want to say thank you for having us here, and also thank you for putting out the most recent State of Medicare Advantage report earlier this week, making these incredibly important points about how the enrollment is now almost 55% of the Medicare population, how diverse socioeconomically the program is, and all the important points of the program that so frequently get lost in the discussion. So I represent America's Physician Groups. We are about 360 medical groups across the country, caring for approximately 25% of the US population. They range from some of the remaining large independent primary and multi-specialty practices around the country, all the way up to, for example, One Medical Senior, now a division of Amazon, Oak Street Health, now a division of CVS, many organizations affiliated with major health systems, UCLA, Mass General, Brigham, et cetera. So we're really at the intersection of everything that is occurring now in the new makeup of American medicine and American healthcare. Very importantly, our groups care for about a third of all the Medicare Advantage enrollees in the country. So we have a deep footprint in Medicare Advantage and a deep commitment to Medicare Advantage. And our happiest members in MA are in delegated relationships with health plans, which means that the risk of caring for patients is effectively transferred over to the groups. Essentially, there is a capitation formula where the groups take the money that they receive from the federal government, hand a lot of it over to our groups, and that our groups have the freedom and the ability to decide how best to provide care. They frequently work very closely with the MA plans. They plan the benefit structure together. They go to market together, et cetera. So that is a model that we believe creates the best healthcare. And actually, we have undertaken a study of our members' activities in Medicare Advantage and compared it to what happens in fee-for-service Medicare Advantage and also traditional Medicare. And we can show that across 26 very important quality and resource utilization outcomes, they achieve the best results. There's a substantial improvement in the outcomes. So what that tells us is there are flavors of Medicare Advantage. The program is not a monolith, despite what you may interpret from reading a lot of the news reports. It's not all the same. And we know that there are avenues in Medicare Advantage that can enable our clinicians to provide the best holistic, patient-centered, coordinated care with beneficiaries in very close partnership with the MA plans with whom they work.
Thank you, Susan. Maria?
So I want to echo Susan and just say thank you. It's really a pleasure to be here, and we very much appreciate our partnership with Better Medicare Alliance. So I am with the Healthcare Leadership Council. It has been around for 35 years, and if you're not familiar with it, we represent really the whole care continuum. So from providers to payers to manufacturers to health IT companies, we really represent the whole, all of the sectors. And what binds our members together, and they are CEOs and C-suite members, and there's about 50 members, and very great engagement. What really binds us together is having a patient-centered care approach to all of the public policy. We're a public policy organization, take positions, make recommendations, And did you ask what the priorities are? I can't remember. You did.
Sure.
Okay.
No, it's
Yeah.
the priorities of your organization,
Okay.
just to
Yeah,
give
just
the
the
allies
three
a sense of
of what
where
we're
your
working on.
focus is. Yes.
So I would say we have three big buckets. One is on what's disruptive. So we're spending a lot of time on cybersecurity issues, on artificial intelligence, on AI. The second is on transforming access. So we, of course, MA, and we'll talk about that, but also value-based care is a big priority, telehealth, and all the access issues. And then we spend a lot of time on promoting private sector ingenuity and investments. So that would fall into the bucket of pushing back on government proposals and plans such as more price setting, more government controls over price setting for drugs, and then weighing in on consolidation proposals.
Thank you. Just as there's the thread of patient-centered care in both of your work and the work that you do with your members, rather than sort of start with the challenges, because I know we'll delve into that, can you give some examples of where in your respective organizations you've had some successes that you believe ultimately have an impact, a positive impact that get to that patient-centered care? Because that's something that we would just love to learn from.
Well, I'll cite the example of many of our groups who, as I mentioned, are in these delegated relationships with health plans and how that has enabled them to transform care. One example is Cedars-Sinai. Many of you will know Cedars-Sinai, a large quaternary hospital system based in Los Angeles, frequently the place where a lot of celebrities go to receive their care. Most people think of it as a hospital only. It's not, of course. It's a major health system in the LA area. What our members who are caring for Medicare Advantage beneficiaries in that context tell us is that in close collaboration with health plans, what they have been able to do is, first of all, turn the sick care system into a healthcare system and a preventive health system. Because through Medicare Advantage and through coding, which of course has a dirty word for many in the press, but it is the way the system was set up, thank you by the federal government. Through coding, clinicians treating them can code for conditions that need to be noted in the medical record, but may not necessarily require a lot of intervention at that point, but need attention. So for example, if somebody has prediabetes, you can code for that, right? If somebody has depression, and of course that's very commonly correlated with conditions like other chronic conditions, you can code for that. That gives you financial resources into the practice to restructure care. You don't just have to be reactive, you can be proactive. And you can say, in effect, all right, I need to support this person who has prediabetes in not transitioning to full-blown diabetes. I need to make sure this person has healthy food supplies. I need to make sure this person goes through the diabetes prevention program, has connections with social workers and other social supports if need be. There are resources that are not available in the fee-for-service system because there's no payment for them or inadequate payment for them. So what they have done is kind of restructured how they care for older adults through the benefit of being involved in Medicare Advantage. And that has had spillover effects to how they care for everybody, because the doctors don't sit there and interview patients when they walk in the door and say, what's your coverage? Are you in MA or are you in traditional Medicare? They don't. They just act very differently than they used to. And they do that because of the resources made available to them through Medicare Advantage and through that supposedly evil practice of coding, right? And what they are very adamant about is, you've read a lot of stories that say people get coded for things and there's no treatment. They will point out there are lots of things that you code for because you need to pay attention to them. And you may not necessarily treat it right at that point. An example that they will offer is, you have a patient who's come in who has been on cancer therapy, chemotherapy, and is immunosuppressed. You code for that. You don't treat it. You're treating the cancer, which is causing the immunosuppression. But you have to be attentive to that, because if you're immunosuppressed, you can be subject to other infections, right? So you have to be proactive. If you're being paid, in effect, to keep people out of the hospitals, keep them from showing up on a non-emergency basis in an emergency department, you have to pay attention to these things. And if people think the fee-for-service system pays clinicians to do that, it doesn't. It's getting a little better, smidgen by smidgen, as codes get inserted into the Medicare physician fee schedule, but it's nowhere near where it needs to be. And that is what they feel is such an important, true advantage of having been in Medicare Advantage and completely overhauled the way they care for patients.
Thank you.
So I'm going to take us a little bit out
Sure.
of the, so I'm going to talk about two areas that I don't know that I call them successes necessarily, but we're optimistic, and so just talk briefly about some of the work we're doing at HLC. So one is, we have, as I mentioned, the whole continuum, all the different sectors, and obviously very worried about this, the onslaught of cyber attacks. So what we, it's just where the healthcare industry is obviously, a specific target. So we put together a rapid response task force. We asked our members who, as I mentioned, are the CEOs, C-suite members, can we have, lend the time of your chief information security officer or other senior executive. And so for the past fewer than 6 months, really, we've been meeting with them. We've been able to come up with some principles on cybersecurity, and we really have put together a team where we can evaluate some proposals. And one of the things that's come out of that is how, what's a pragmatic way to tell policymakers that some of what you're proposing is a little challenging. It's unrealistic to make us, have requirements to be up and running in a certain amount of time. Ignores the fact that, of course, everybody wants to be up and running as quickly as possible, but you need to have better information on how much information you're requiring, the injured party to give, because the bad actors are still obviously watching this. So things like that, we've really we've taken the value of our diverse membership and said, whether it's a hospital or a plan or other players, and we've come up with some good ideas that we'll be using. And then the other one is on telehealth. I mean, of course, like most people in this room, we're very focused on the short term, making sure the flexibilities are extended before the end of the year and doing a lot of work there. But we're also encouraged that the Congressional Budget Office recently put together a presentation saying that they have some additional questions, because we really want to debunk the theory that telehealth visits and all services are additive. So we're using, again, the full spectrum of our membership to say, here's some information, here's some data that can show you that not only is it not additive in many cases, but you are having treatment in a less high intensity setting. So those are just two areas, in addition to all the the topics that we'll talk about, that we're seeing some encouraging signs and making good use of who we represent.
Well, and I do think, Maria, when talking about successes, it doesn't mean that it's a success and it's done. Like, I think we are all practical here, that as long as we're on some pathway where we're going in a direction where we can, so there's reason to be optimistic for that reason. On the other side, as far as challenges, I want to sort of raise something environmental first before trying to get a sense of the challenges that you see on some of the issues before your members. And what we see in MA is, yes, there's been a lot of different policy changes over a period of time that we see negatively impacting beneficiaries. But in addition, and your members are impacted by this, we see the aging population, and we see just high utilization, and then we see fiscal pressures. And that affects anyone in the healthcare space, whether or not you're in MA or not. And so just curious for you to speak to those challenges in the environment and how that translates to the work that you're doing.
Do you want to go first? Or I'm happy to.
Yes.
So absolutely, that we are very concerned about aging. I mean, when I was asked recently, what keeps your members up at night? That's one of the questions. I mean, that affects everything from our workforce challenges to how are we going to be taking better care of people? How are we going to insert value-based care? I think overlaying all of this, and whether it's the challenge of the aging or others, is the fact that there's such a focus on cost, whether it's here in Washington or outside of Washington, and cost becomes synonymous with skepticism about things, that people don't fully understand the complexity of our industry. I think we have a challenge in Congress with seeing that the turnover in some cases. I mean, a recent statistic I saw that, looking at tax reform, in 2017, of the 23 Republicans who were there in the Ways and Means Committee, only 5 remain. If you put that into our industry, which I would argue is even, frankly, more complex than tax reform, that's a big challenge. So I think we all have the challenge of making sure that there's a digestible amount of data. Your report is, I think, the perfect example, Mary Beth, of putting together data that is explainable, understandable, and repeatable. And we similarly try to do that with our partnership with Medicare Today. So we put out a survey now for the past 15 years. And again, the point of all this is, when we do have a successful public-private partnership, let's make sure policymakers understand that, and that they're not just focused on the immediate issue of cost. So we put together this survey, and over 90% of seniors say that they are satisfied with the program, and that's been a constant for 15 years. And then, no surprise, there's increasing nervousness and skepticism about government setting prices for drugs. Over 80% in each area said that they're worried about limiting access to their existing medicines. They're worried about reducing treatments. They're worried about the availability of new and innovative drugs. So it's important to make sure that we're conveying all this information and not taking for granted that people, in positions of directing policy, fully understand how complex the whole industry is.
And is that survey internal, or is that on your website?
That's on the Medicare Today website. Yeah.
Okay. Thank you.
So this issue of the booming population of aging baby boomers, largely is what we're talking about, is of critical concern to our members. We all know that the leading edge of the baby boom, born in 1946, will be 80 in a couple of years. And we know that healthcare utilization, if it starts to go like this at 65, at 75 it goes like this, and at 85 it goes like that for those who are still with us. And characterized, of course, by multiple chronic conditions and lots of expense. Mike Chernow and his colleagues at Harvard have projected that the average Medicare beneficiary will be spending 40% of income on healthcare costs, 40% of income by around about the year 2030. And that's largely driven by the utilization that's necessary, many more visits to physicians to deal with chronic conditions, et cetera. And you put that up against what we see in the existing physician workforce, particularly the primary care workforce, and there simply are not going to be enough doctors to see these folks. And already, as we know, wait times for, if you're a patient trying to get a visit with a new primary care physician, new to you, you can face, even in this market, a 6-month or more wait. If you try to get an appointment with a specialist in many markets, it can be 6 or 8 months or more. And that's today. That's not 5 years or 10 years from now. So our members are saying, how are we going to deal with this? And their answer is, we have to restructure the delivery of care. We have to move away from a model that is based on a notion of one clinician and one patient and visits in the conventional way that we thought of them. That we have to think about teams of people across organizations who can provide care. So maybe there's a physician who's leading the team, but who else is on the team? Nurse practitioners, physician assistants, MSWs to deal with social issues, pharmacists, et cetera, et cetera. So we have to get away from the single physician model and one clinician, one patient. It will be increasingly, people believe, team-based. And of course, because we're going to be talking about doing the kinds of things that the fee-for-service system, again, does not really reward clinicians for doing, it means it has to be a value-based payment model. just by definition. Because think about all those people on the team who cannot bill Medicare, right? Most of them, right, don't have billing authority. So there has to be money that comes into practices that the practices themselves can decide how to expend the resources to hire the right people on a team. And then beyond that, thinking about, well, how much care do we not do in person, but do we do virtually? Lots is the answer. How much self-care do we try to engender among people? Teaching people how to do a better job taking care of their chronic conditions at home. And by the way, how much care do we move out of all institutions to the home? And those are the priorities that a lot of our members have now. And now they're trying to figure out how they pull together all of these puzzle pieces, because just on the basis of the workforce alone, they know they're going to have to reinvent care delivery. There simply are not enough people going into primary care. I saw a statistic recently that for everybody who is today in an internal medicine residency, theoretically training to be in a form of primary care, 4% of them say they will go into primary care. And the rest of them intend to go into an internal medicine specialty or subspecialty, because that's where the money is. That's where the money is. So how are we going to put all of these puzzle pieces together? That's what our members are trying to do. And they're pretty darn sure that the payment model has got to be value-based care, including Medicare Advantage.
Just as you bring up value-based care, Susan, and I know that's a priority in your space as well, Maria, where do you think there's a next, as we're transitioning more to value-based care? I mean, given where we were 5 years ago, we weren't having the conversations that we're having about the importance of it right now. But where do you see what's next in the value-based care where there can be more partnering and collaboration with the diversity of the various players in the healthcare space? Maria?
Yeah. We just put together an event last week on social drivers of health. So we do see that as a possibility, of making sure that that's also covered. I mean, the statistics are really incredible. Actually building on the statistics from your report about who's in Medicare Advantage, but thinking that 80% of health outcomes are affected by social, economic, and environmental factors, and that alone. We put together this event where we had all different folks from government, from private sector, from academia, from community-based organizations, really trying to look at how do we make this shift and what are the determinants. And the big issue is actually how are we going to pay for these interventions? That's a major issue here, along with what are the appropriate interventions that should be in the healthcare space. So that's one area, though, that we think is extremely important and related to how we move on value-based care.
Thank you.
Yeah,
and I love the timeliness that you just had your gathering last week on this.
But yeah,
so
good
topical
timing.
it is.
Yeah.
We would agree, because it's going to take all kinds of partners to, again, back to this population we were talking about, older adults. Partnerships, we have a partner of ours called the Partnership to Provide Social Care, which is organizing hubs around the country and basically showing people examples of hubs that bring together community-based organizations, so that there is a referral mechanism and a feedback loop when a healthcare provider writes a prescription, say, for healthy food to be delivered, that referral can go through the hub to an appropriate community-based organization that can deliver the care. And there's a feedback loop. It goes back to the provider that, yes, this food was delivered, this patient is being taken care of, because that doesn't really exist to a great degree in the current system and must exist, particularly if we're going to have a rational means of doing this and a payment mechanism to support it. So that's number one. But I would say we need all the partners all together pulling the oars in the same direction, right? We need partnerships with hospitals, and we have them. Like, I give you an example of another of our members, Sutter, which has recognized that the future is not going to be building more hospitals and filling up more beds. The future, if anything, is going to be emptying out the hospitals. Not that they will be empty, because they will be full with a lot of these sick patients, but it's just the whole construct of we're a hospital system and we're going to build more big hospitals and we're going to fill up the beds. I don't know rational health system leaders nowadays who are thinking that way, because they recognize when it costs about $2 million per bed to build a hospital in this day and age. I mean, how many organizations have access to the capital markets to even afford that, right? So they're not thinking this way anymore. And at Sutter, they're thinking about how do we spend $900 million now to build more ambulatory facilities, because we're going to do more care outside of hospitals. And we're probably going to push more care to the home, as I've said earlier, through approaches like hospital at home and what's now called advanced care at home, by organizations who want to break this connection even to the hospital and say, no, we want to keep people in their homes as long as possible. We don't want them to show up at the hospital first and then get referred back to hospital home. We want to keep them at home in the first place. So we need those advanced care capabilities to be able to go into the home. So everybody's got to have a common vision of the future and a common grasp of the fundamental realities and push toward that. And again, I think it's pretty clear that's going to mean a break from the current payment system and invention of this, building on this platform that value-based care gives us to support transforming the system from sick care to more to health care and preventive care, and being paid to do things to keep people as healthy as possible, not just being paid to take care of people when they're sick.
Yeah, I would add everything. We agree. I agree with everything Susan said. And the hospital at home, one of our participants was the head of hospital at home at Mount Sinai, one of our members. And I just add that we are coming, it wasn't only an event, we are also coming up with a policy brief with recommendations from all of these discussions. And we're hopeful that it will make some headway there. It's really an important topic, and it's hard. It's a hard one though, because of all the pressures and the cost and some of the skepticism about where do some of these interventions again belong, in the MLR or not in the MLR.
Right.
So that's the really the crux of the problem. There's a lot of agreement about how useful and how food and housing and all these things will help, but that's the hardest part, and but that's what we're hoping to tackle.
Mm-hmm. That's great. Shifting gears a bit, but to an area that I know is a priority of both your organizations, is health equity. And yesterday we had a fireside chat with Juliet Choi, who's the president and CEO of the Asian American Pacific Islander Health Forum. And some of the areas that we focused on was just, again, bringing awareness to health equity issues, but just some of the discrimination issues that translate to issues of access to care, but then also just communication. And again, in your respective organizations, if you can just speak to what you're hearing from members, both on where they see health equity being a priority and what their work is in that space to try to make a difference ultimately for the patients.
Our organizations see it as a huge priority, and they believe that they're living it, partly because a lot of the enrollment in Medicare Advantage is the population you all have identified in your report. Mm-hmm. It's a population that is more Black than the population that is in traditional Medicare, mm-hmm. as your data indicates. It is a more Latin population than the general population, mm-hmm. in traditional Medicare, and it is a more socioeconomically diverse population, mm-hmm. All of which raises a lot of suspicion around the assertions of MedPAC that Medicare Advantage is adversely selecting the healthiest people to go into Medicare Advantage. It just cannot be true, mm-hmm. in our view, and our groups don't think it's true, mm-hmm. that they're getting the healthier people enrolling in Medicare Advantage. So by definition, they're dealing with a population that is the target of concerns about equity. What do they do? And again, why do they like the Medicare Advantage model? because I'll give you an example. One of our members, Oak Street, now part of CVS Health, in the ACO REACH model, and of course the E in REACH stands for equity. And there are provisions in that model that specifically help to engender an equity-oriented approach, like a equity-based benchmark adjustment, et cetera. So what does that give them the ability to do? In inner city Chicago, where they have a very important beachhead and take care of a lot of older adults, they've learned that many older adults are grandparents and they are caring for their grandchildren all the time. Why? Because the parents are working, the parents have other issues that can't care for the children. So in order to get these older adult grandparents to come into the clinic to get the kind of preventive care that they want to provide to them, they had to bring their grandchildren with them. So what have they done? The clinics are organized so that there are play areas for grandchildren. They basically pay for the grandparents to buy car seats so they can put the grandchildren in a car seat and into a taxi or car to bring the grandchildren along to appointments, right? These are things, those of us who have been used to going to a regular old practice, I mean, maybe way back in the Marcus Welby days, Marcus Welby anteed up for car seats, right? But that is just not happening in most of American healthcare. But it's a recognition that people have real lives, and they may care about their health, but they're also caring about a whole lot of other things because of the conditions and the circumstances in which they live. And unless you're creating a system that can meet those needs with a payment that follows to meet those needs, it's not going to happen. And so that's just an example of how they bring equity down from this conceptual level to just the day-to-day practice of medicine that is truly equitable in every respect.
Similarly, I mean, our members, this has been an issue for years. We have a permanent, focus on this. We look at public policy through the equity lens, as we, particularly on the access issues. So when we're doing, even on a topic that doesn't seem related, cyber or MA, if we're doing principles and things like that, we're focused on the equity part of it. And then to the examples, I don't have any right off the top of my head, but we have companies ranging from J&J to McKesson to Pfizer to hospital, first-class hospital systems. They're all focused on it, not only on how they relate to customers, to patients, but also employees. So it's I mean, without question, this is a major issue, major ongoing challenge. I think everyone sees that we need to make sure that when the health equity remains steadfast, number one.
Well, and I also want to recognize, as we had John Blum, the Principal Deputy Administrator of CMS here yesterday, and their COO, we talked about health equity as well, and just the leadership of CMS making this a priority. And, I know we've been talking about health equity, and we're all looking for, action and results, but, this does take time, but there's certain elements of, progress I think we're already seeing, and just continue to be collaborative on the solutions. Coming back to Medicare Advantage, again, I know, Susan, you said of your members, they're serving, I think, a third of the MA beneficiaries. Maria, I know you have a MA working group within HLC, again, given the diversity of your healthcare membership. And as much as I know, we've been, referencing, in this discussion, a lot of the value of MA. I both had conversations with John Blum and with Jim Reckton, the Humana president and CEO today, that where we're wanting to protect the program, we need to continue to strengthen it and improve it. And so if you could just both speak to what you hear from your members who are serving the MA community, but realize there's areas that we need to improve, and just sort of curious of knowing where they are to sort of know that those are areas that we can be working together on. And I'll just give, a couple examples of BMA's work in the area of providing marketing recommendations, especially as we're getting to open enrollment. How do we make that less complex for seniors Also, we've been talking about prior auth and, one level of progress, and we see what happens with legislation, but there's, more to be done. As prior auth is an important tool, but again, how do we have it serve seniors more, and the bipartisan bicameral legislation that, Congress has agreed on. So I use those as a couple examples of solutions and where we need to, improve in MA. But I'm just curious what you're hearing from your members and what you're working on and where we could collaborate. Maria?
So, well, I've mentioned a few times we have a diverse membership. So as you can imagine, we talk about MA, but let me start by saying how supportive HLC is of Medicare Advantage, and this is the most successful public-private partnership, and everyone wants it to succeed. That's without question. But as you can imagine, we spend some time talking about some of the frictions that have come up, and that led to this MA work group, which was started, I think, back in January, where we had some frank conversations about where are the frustrations coming from. Some of it's from the processes, that folks feel have exacerbated certain situations. So we spent some time, first and foremost, and we reached our first objective of let's put on paper what we agree on. We agree how important the program is. We agree it must be sustainable. We agree it must have great access, and everyone should have access to it. And that goes also to the equity issue. And then we agree that it's very valuable to demonstrate the value of these supplemental benefits. So we've agreed on all of these principles. And I would say our next phase is to see, we're taking the principles, trying to evaluate different proposals, whether it's coming from Congress or just, other private sector initiatives, and how can we move to the, if necessary, to the next phase of how else can we contribute to finding solutions to some of these pressure points. And so we're continuing the work, but again, we're really happy to be here. We're happy to partner with you. We can't say enough about how important the program is. I mean, whether it's value-based care, social drivers, or how all these issues that we're talking about, it's really important that this succeed. And we want to be part of the solution of addressing some of these issues. I heard what some of the other policymakers said yesterday, and it's concerning that there's this increased focus, and it sounds like skepticism from some parts of Capitol Hill. And we need to make sure that we are getting the word out of how important it is and what the accomplishments that we are seeing.
Thank you.
Right, with 55% of the beneficiaries in the program, it's time to turn from skepticism to open-minded sense of how do we strengthen the program, how do we improve it. We are developing a set of policy proposals now that we'll bring out for the next administration on what to do about MA. But in the meantime, we have 3 immediate priorities that we've been working on for some time. One is we do think it's important to recognize that MA is not monolithic. Mm-hmm. There are stronger elements of MA and less strong, depending on who's doing it. And we think, and we have periodically said to CMS, you should take star ratings and incorporate a star rating that rewards plans that engage in these delegated relationships with providers, because we can show you that they produce better results, right? So why would you not consider that an important enough aspect of quality that you would reward that and therefore stimulate that? Because as we know, when you put something into a star rating, plans pay attention. And we think that the whole plan arena, we have members, Heritage Medical Group, one of our big members in Southern California, serves 1 million people, and they have delegated relationships with 17 different health plans. So we know it can be done, right? So why isn't more of it being done? And we think more of it would be done if it got rewarded in star ratings. Second area of concern that we have is risk adjustment. We understand that the current risk adjustment model is flawed. It's not necessarily, it certainly is lacking, at least in many areas of the policy community, a sense of suspicion about it. We think there are a lot of blunt instrument proposals floating around out there. For example, MedPAC has said, as we know, what if we just got rid of all codes that came about through health risk assessments or through chart reviews. Our members would say back to that, no, they as physician groups undertake health risk assessments, and they do chart reviews because it's important to make sure that coding is accurate. So don't go with a blunt instrument approach here, but do things that will make it clear that when you are diagnosing a condition, you have a treatment plan that is parked in the electronic health record that could be subject to audit, that shows that even if the treatment plan says, we're not treating this right now, but we're watching it to make sure it doesn't develop into something worse. We just think there are all kinds of opportunities to capture the day-to-day practice of medicine and coding and things that should be documented in the electronic health record, and then show that these things are accurate. And that is going to require moving away from a lot of the current practices around coding to something that is absolutely possible, even if it will take some years to accomplish. But that's the way we think the system needs to move. And we're working very closely with our friends at the Duke Margolis Institute to come up with some policy proposals around moving risk adjustment to a new platform. And the third area is prior authorization, which again, our groups, especially our delegated groups, they're doing prior authorization themselves. This doctors doing prior authorization for other doctors and patients. Why? Because we know there's a whole lot of low value care being provided, right? It's probably 25 or 30% of health spending is questionable, if not wasteful. And it's things that get done every day to excess, stenting, et cetera. So there has to be some element of utilization management and prior authorization. Question is, how do you make it so it's less painful for people? And even our organizations, our physicians will complain about prior authorization that is done poorly, that is done by people who don't seem to ever have any knowledge at all about medicine or healthcare. We know from the Inspector General's report of a couple of years ago that most of the prior authorization decisions that were reversed were a function of human error. People just made mistakes when they were doing prior authorization. And of course, we know that's the only area where human beings ever make mistakes, right? Is in prior authorization of Medicare Advantage. So we know that there are ways to do that better. Electronic prior authorization is obviously one key, but we would point to Gold Card initiatives as another feature. United Health Group just announced a big Gold Card initiative where physicians who can demonstrate that they're practicing evidence-based medicine get kind of almost a free pass for a certain set of conditions and codes that they might be otherwise have to make a prior authorization request over. They will not be subject to the PA request. We're wading into the details of that UHC, I should say, Gold Card program now to fully understand it. But those kinds of things make a ton of sense. And you can do that in a delegated model where you are very carefully selecting the clinicians who are in your network and they are practicing value-based, evidence-based healthcare. So we think there's a lot of opportunity to make some really positive changes, and they will strengthen the program in the long run. If for no other reason, they will also enhance public trust in the program, which we think is critical.
No, could not agree more. Well, I appreciate being able to close on a solutions-related theme as we wrap this up. And I just want to thank Maria and Susan for your leadership in this space, your collaboration with us as BMA allies, and just the respect that your organizations have. And looking forward to the work that is going to come out of your respective organizations on these solutions where we can support and work with you on it.
And thank you for your incredible leadership, you and your organization, and all the allies who are members of BMA.
That's right. Well said. Thank you, Mary Beth.
Well,
Thank
you
you,
guys
Susan.
included.